Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla. I'm a pulmonologist practicing sleep medicine in Minnesota. Today's episode is sponsored by Harmony. We've had a few discussions about residual AHI on a download and how to determine if someone's sleep apnea is fully treated. Many of these discussions center around patient symptoms, including residual hypersomnolence. More recently, we have looked at the residual AHI on a download and discussed whether an AHI under 5 is our target or if it should be lower or higher. These discussions assume that the residual PAP-determined AHI is accurate. What if this assumption has been incorrect? Dr. Sahil Chopra has been comparing PAP-determined residual AHIs to cardiopulmonary coupling-derived AHIs to see if perhaps we have been overlooking undertreated sleep apnea based on this metric. He recently published his data looking at thousands of downloads and comparing those results to the ones obtained via objective testing. He joins us today to discuss his work. Thank you. Happy you could be here today.
Oh, hi everyone. Nice to be here too.
So I read this paper. I thought it was very interesting. Can you summarize it first? Tell me about this paper.
So, the way our clinic has been operating, our patients basically own a PPG-based sensor.
They own
And
it.
yeah, we just give it to them. We say, here, this is for you.
Ah,
Thanks for being a patient of our practice.
okay,
Here's a sleep image ring. Is for you to keep, test as often as you need to.
okay.
And I'm going to use the data from your sleep study device to help you optimize your sleep health, irrespective
Oh,
of irrespective of whatever sleep disorder is going on.
so
So
everyone gets a sleep image. It's not just the
yeah.
people who are undertreated. Okay.
Hmm.
Yeah.
Go ahead.
So is that their baseline test then? Or is it done via something else, like a flow-based HSAT?
We do flow-based testing about 5 to 10% of the time.
Ah,
We'll end up using an Onera-based uh, level 2 study, or we'll order an in-lab study
okay.
where I feel like the PPG-based analysis is is not telling the truth, or
Okay.
like a WatchPat or a Sunrise. And we also use Enzo for
Oh, so you use everything.
analysis. And yeah, so we use it. We're at the end of the day, we want to be test agnostic
Yeah.
and
Yeah.
treatment agnostic to provide good sleep medicine care to patients.
So you're using the term PPG, but then in your paper you also use cardiopulmonary coupling. Are you equating the two? Help me
Well,
understand that.
PPG is the signal. CPC, so photoplethysmography is that raw signal that is captured with these oximetry based sensors. And that data could be analyzed in a variety of different ways. It could be analyzed by a CPC algorithm, i.e., in this case, sleep image, but it could also be analyzed with an AI algorithm, i.e., Enzo,
Enzo.
Enzo data,
Okay.
right?
Yep.
Enzo is an
Okay.
AI based system. And so we're at the end of the day, uh, test agnostic, but
Mm-hmm.
PPG is just a really phenomenal tool from a cost effective standpoint to track sleep over time. And so we've been using that for almost 4 years.
Okay.
So to answer your question, so when we prescribe someone a CPAP machine or a dental appliance or Excite or anything along those lines, we just naturally get to see what happens to their sleep across time.
Okay, that's kind of
And
cool.
yeah, it's fun. It's fun. And it's you'll be we're surprised often of this is what I was expecting, and that's not what happened. And it sort of allows us to unpack, what's going on. But so this idea of CPAP and sleep testing data, we've been doing this for a while, and it has been just an observation that,
Okay.
hey, when we prescribe someone a CPAP machine and we look at the AirView download report from their ResMed device, that tells a different story than what does a PPG based sleep testing
Yeah.
solution if they are tracking their sleep while using a CPAP machine.
Yeah.
We've known this for a while, but I think everything is quackery until you publish it. So that was kind of the reason to publish, in peer
Okay.
reviewed literature that, hey, the guys, like, there's something to unpack here.
Yeah.
Something might not be telling the truth, and would love to get everyone's opinion on this.
Yeah, so tell me a little bit. I read some in the paper, but tell me why you chose, like, why do you believe sleep image over the residual AHI?
So, so just for clarifying the terminology,
Yeah.
we'll use the term AHI flow,
Yep.
derived from flow from the PAP device,
Yeah.
and AHI from a CPAP machine, and AHI CPC,
Okay.
derived from like a PPG-based signal, in this case,
Okay.
sleep image and cardiopulmonary coupling.
Yeah.
And, you know, the reason it's easy for me to believe the PPG-based signal is because we have access to the raw data. So,
Mm-hmm.
like, our patients can upload the SD card flow data that comes from these CPAP devices like Sleep HQ or Oscar, and you can actually look at breath by
Yeah.
breath analysis.
Yeah.
And you see a ton of unscored events that the algorithm does not flag.
Yeah.
And then you do a sleep study for that person, and you look at the raw PPG data, and you see like an arousal type of change in pleth amplitude.
Okay.
And when you zoom out a bit, you can see desaturations, and you can see heart rate rise. So you see like the physiologic change happening
Yeah.
when you align the signals from a PAP device and a CPC based sleep study. And
Yeah.
it's like so it's not like, why do you believe this? It's like it's sitting in front of you, and you
Yeah.
can see the desaturation and the autonomic response and the missed
Yeah.
event on the flow tracing. So it's kind of, yeah. So
Yeah.
it's
It's
there.
had a lot of
It's there.
it's had a lot of scrutiny lately, right? The flow, the AHI flow, which I mean is
Yeah.
important in our field, right? So is this like it's solid enough, right? You see the desaturations, you see the pattern. So do you ever follow it up with PSG, or is it solid enough to be actionable?
Um, you could. That's probably ideal. Like, if I had to
Okay.
do this in a prospective way, that is like
Yeah.
the the most evidence-based way to do this, and this is more of a real-world sharing of, like, this is what we're observing. But what we do observe is, if you make changes to the CPAP, or like in terms of pressure, EPR, fix a leak, or you use a different solution, you see their sleep change.
Yeah.
So, like, you can try to make tweaks to the device to try to get people as, breathing as optimally as possible. But sometimes it's like a real challenge. Like, people have really fragile breathing and
Yeah.
fragile sleep.
So are you kind of pulling out a cohort of people who are symptomatic, or is it based on the sleep image data?
This was all comers.
It was because it
This
was a
was
lot of
all
nights, right? It was almost
Yeah.
25,000 nights. Yeah.
Yeah. This was all comers
Okay.
across like a 2-3 year period. And we just basically queried the database, like, who are all the people that are that are using the CPAP machine,
Okay.
and then uh, how many of them, like, how much nights of sleep testing do we have, and then sort of we went back and uh, used AI to do a lot of the analyses.
Yeah, I kind of wondered about that because it was like 465 people, right? And then like almost 25,000 nights, but it wasn't like everybody had 20 nights. Like one person had one night,
Yeah,
one person had like 700 and change nights, and like the
yeah,
average was like
I,
22-ish.
yeah. That was the median, but I think the
Yeah. Oh,
minimum is
median.
got to
Okay.
be at, yeah, the minimum is like at least. I would have to go back and check, but
Okay.
the minimum is still like in the single digits,
Yeah.
because um, we do like a 7 to 10 day baseline assessment for everyone. to get a sense of like what is your sleep like on weekdays, weekends,
Okay.
before I even start them on anything, unless if they have like really severe hypoxic apnea. But like for most people, like we'll
Yeah.
do like a multi-night assessment.
So, like at their baseline, they do 7 to 10 nights. Okay,
Yeah.
that is very cool. Okay. And so in the data, it looked like there was a bunch of nights where the flow AHI was under 5, but a ton of those had an elevated AHI, like CPC AHI, like 85%.
Yeah, it's a big number.
It's high, right? But that was
Yeah.
3%,
Yeah, that
right?
was a 3%.
Yeah,
Yeah.
yeah, yeah.
Yeah.
So what else? But you looked at 4% as well as
Yeah,
ODI 3%, 4%.
we looked at the ODI 3%, AHI 4%, ODI
Yeah.
4%, and the closer you get to the ODI 4%, the closer the agreement becomes of the AHI flow to the
Okay.
ODI, like the least
Yeah, yeah,
sensitive
yeah,
metric.
yeah, yeah.
Um, but generally speaking, the ODI 4%, if like AHI from flow from a CPAP machine was like 2, I think in the paper when we did the analysis, the ODI 4% was like, I don't know, 6, 7, 6 or something along those lines. It
Yeah,
was still high. It was still like greater than what one would, I think,
yeah,
call like controlled sleep apnea.
yeah. Yeah, because I think like it was 12-ish on sleep image, and then when you looked at AHI 4%, it was still like 4.5 different. So
Yeah,
significant, right?
totally,
And so
totally.
it's super high. When it said 85, I actually had to read it twice. I was like, really? Like that's really high. And
Yeah.
so like one of the things I appreciated that you commented on was that you couldn't necessarily tell if they were on CPAP or off CPAP.
Well, yes and no.
Okay, tell me.
What we went back and did was we looked at what was the total time of sleep testing, like what was the duration of
Yeah,
sleep testing,
yeah,
and what was the total time of like CPAP usage.
yeah,
And that number was like very small and it was
yeah.
not statistically significant.
Yeah, they're
Um,
both like more than 7 hours.
yeah, yeah.
Yeah.
So I think the reviewers they asked us to look at that, and
Oh, that's where that
because
came from.
yeah,
Okay.
they were worried that like how much of this is because the patient is off, quote unquote, off therapy,
Yeah, yeah,
and
yeah.
is that like resulting in this like AHI number to be falsely elevated? But
Yeah.
that's not the case. Like even
Yeah.
there might be that could be a contributor, but
Yeah.
that does not tell the entire story of like that there is like a pretty big delta.
Yeah. But I mean it's fair and it's good that you looked at that, but it's still pretty compelling that even though we have this sort of reassuring flow AHI, objectively there seems to be significant like undertreated disease. And so what I'm kind of wondering is, the traditional model is somebody has sleep apnea. They, even if they look well treated on their CPAP, you bring them in for titration, right? And just sort of tweak or what have you. Um, how does this change that? Do you just make pressure changes based on the sleep image data?
Well, I think it changes a lot of things.
Yeah.
See, well, the first is you can make changes like tomorrow versus saying, "Hey, I'm going to bring you back to a lab, and I need to get a prior auth and yada yada
Yeah,
yada."
yeah, yeah.
Right?
That's
So you
fair.
can
Yeah.
just
Yep.
it's like it's real time. It's in the
Yeah, yeah,
comfort.
yeah.
It's in a real like home environment. So
Okay.
you can kind of sense, hey, like when this person uses like a hospital thin pillow versus when they're using like a pillow that's elevated, a different
Yeah, yeah.
mattress, a different different environment.
Their dog in
Um,
bed. Yeah.
yeah, yeah, no, totally,
Yeah.
100%. So you have like real world
Yeah.
data in real time. It's like hyper convenient.
Yeah.
Um, the other thing is that I think is probably like the coolest is you can actually see it forces us to step away
Okay.
from like what is like the change in AHI. A couple of things. One is
Yeah,
it
yeah.
forces us to step away from like this change in AHI of like this is where they were, this is on CPAP. But because you get all this information from a sleep study, it's like, dude, what happened to their sleep?
Right.
right? Like do they
Right.
have more deep sleep, REM, light sleep? Do they have more movement? Do they have sleep fragmentation, sleep
Mm.
quality? You can start
Well,
to see all of these different biomarkers of a sleep study change across time. Um, like, which I think is like the coolest part about this, because some people's sleep quality just goes almost a third. It just goes down the drain with the
Yeah.
CPAP machine. Breathing gets better, but sleep
Yeah. Yeah.
gets
Yeah.
worse.
Yeah.
Objectively speaking, right? And so I think there's tremendous value in approaching it this way. One is obviously like the fast feedback loop of like making changes in a real world environment, but two, then you get to see sleep and see, hey, like what else can I do to improve this person's sleep health?
So help me understand this. Like, are there certain populations where we know that the flow AHI is going to be less accurate?
So like particularly in people who have like short cycled respiratory events, unstable breathing, if they have a ton of leak, like that
Yeah.
residual AHI during that time, like it just can't be accurate because there's
Yeah.
all this leak that's happening. And
Okay, so hang on. You said short cycle. I thought it was long cycle periodic breathing in the
or
paper.
both, even
Okay,
both, like these, like
both.
yeah,
Yeah.
so both, like you can even, like when you look at like the flow tracing from a,
Yeah.
I would invite every one of your sleep medicine, all the sleep docs that listen to this, like just open up like Oscar
Yeah.
and or Sleep HQ, any of these like really interesting platforms, and just look
Yeah.
at the data, and you'll be like blown away by, like, man, you see all these events that
Yeah.
we're not used to seeing, and they're like not flagged. And some of these are post-arousal central events. These are like hypopnea events that are just like not scored.
Yeah.
Um, so there's a ton of events. So it's a mix. It's like these short cycled breathing. It happens when there's leak. You also
Yeah.
see certain events that get missed, like particularly sometimes during REM sleep. So it's
Yeah.
not like a fixed thing. I think it has to do with like the sensitivity of the algorithm of, if something changes in a specific way, it just, or in too short of a time period, it won't
It can't.
flag that as an event.
It can't figure it out. So can I tell you something that actually made me laugh out loud when I was reading it? I saw the term unstable breathing and I was like, hmm, I bet Dr. Thomas was part of this. And so I had to like I flipped to the back and I was like, yep, sure enough, Robert Thomas.
Yeah, 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 yeah,
Yeah, so
yeah.
that was awesome. So so let me ask you this. Let's say the flow AHI is under 5, but the sleep image AHI is higher than you want it to be, but the patient feels better. They're not snoring, they're sleeping well, their sleep is restorative. What do you do with that?
Everything is based on like spectrums. So like let's
Okay.
assume the AHI flow is less than 5,
Okay.
and the AHI by sleep image or CPC is like 20.
Oof.
Like, and you visually see desaturations in REM. The patient
Okay.
is like better. They
Yeah.
came with an AHI like maybe, I don't know, 70, and now it's like 20. So they're better.
Yeah.
That means that there's still room for improvement,
Yeah.
and the machine is missing a whole bunch of events. So in those situations, do you go up on the pressure? Do you go down on the pressure? Do you have them sleep on the side? Do you add an incline? Do you change the
Yeah.
mask? Do you tinker with EPR? Like there's a lot of different
Okay.
things one can do in that situation.
Yeah.
So fine is a better term, right? Like,
Okay.
but like what we're trying to mitigate is, which I think is the most evidence based way, is like, have we resolved their hypoxia? Number
Yeah.
one,
Yeah.
have we achieved some degree of, so these are like physiologic biomarkers to me that look
Okay.
mean fine. Like, have we resolved hypoxia?
Yep.
Have we achieved some degree of like heart rate dipping during sleep?
Okay.
Like, where did they start and where did they end up?
Yep.
And have we sort of improved the architecture of sleep in the
Okay.
sense like there's less fragmentation and more sleep consolidation.
Okay.
Okay. Um, so let's say you start to do that, but they still have hypoxia or they have a lot of sleep fragmentation or
Yeah.
they have. So then there's work to do, right? There's something that we
Okay.
can make
Yeah.
changes. But like, let's say you have someone who got started on CPAP. Their start baseline testing was in AHI somewhere between, I don't know, 15 to 35 over like this 7 to 10 day window.
Yeah.
And you started a CPAP machine, and their AHI flow is down to 10, 11, 12, 13,
Mm.
14, something in that, like, between 10 to 15.
Yeah.
And they feel better and there's good physiology of sleep, then maybe we're done.
Okay.
And it's like, let's just track intermittently and make sure that you continue to feel better over time.
Okay.
So it's patient. The fine is like patient specific. Like, what was the complaint that they came with?
Yeah.
Um, are those symptoms? Are the symptoms better? And what
Yeah.
was the objective sleep that they came with? And is there like sleep better? And that's how
Yeah.
we sort of and we're figuring this out. I don't, what is a meaningful outcome. I think what the evidence supports is resolution of hypoxia and a more stable autonomic nervous system during sleep,
Yeah.
heart rate dipping, all of that stuff. But all
Yeah.
the other stuff is, I think, is sort of like to be determined.
Well, it's kind of that conversation, right? About like you're better, but are you all the way better? Like when you're trying to look for maybe another, like a hypersomnia or something like that, and
Mm-hmm.
sort of the recognition that, yep, we're all happy you're better than you were, but could you be better yet?
Yeah.
Um, do you ever get pushback? So, okay, so patients look at their residual AHI on their machine, right? And they're like, yep, it's 2, it's 1, blah, 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 blah. And then you have this objective testing. Um, does it ever make them kind of lose faith in their machine?
No, it actually, in the beginning,
Yeah.
I'm glad you bring the people used to say, "Hey, you're lying to me."
Yeah.
Patients would say that, "Hey, doc, I think your ring is incorrect." Um,
Ah,
and
okay.
because like people, ResMed is like such a big, it's like a
Yeah, 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 yeah.
$40 billion market cap company.
Okay.
And they'd be like, "Hey doc, I think your ring is wrong, or the ring is like overestimating." And
Yeah.
then you show them the data, like, all of this, you have these PDFs and stuff. It's like, "Hey, look,
Yeah, yeah,
you have like these, you see these drops in oxygenation on this
yeah.
oximetry."
Yeah.
And so it took time. And that's one of the reasons why we published this too,
Yeah.
is
Okay.
because it creates credibility of like what we're doing is like not a hocus pocus way of
Yeah.
approaching, sleep health.
Yeah.
And but we just tell patients, hey, like we give them the heads up that, hey, I'm prescribing you something like a CPAP machine, and just as an FYI, like there's going to be usually a discrepancy of about 10 in the numbers.
Oh, you do say
um
that. Okay.
yeah, and
Yeah.
but like my target for you is going to be somewhere between like 5 and 15 from a ring based AHI, and
Okay.
under 5 based on AHI flow.
Okay. Is that because you're using the 3%?
That's because we're using the
Okay. Yeah.
3%. Yeah.
Okay. That's interesting. So it actually helps you maybe get a little engagement with your patient.
Yeah, totally.
Okay.
They really, I think there's a selection bias, right? People who come to us,
I wondered.
there is a very clear selection bias. People who want to improve their overall health,
Yeah.
um, and sleep in particular. So there is a lot of engagement. They like to nerd out on this, and people connect their data to all these interesting LLMs, and so it's really cool. We actually have an AI built into the app of like how would Sahil look at, or any of the docs here look at the data. So it looks at the data and
Stop.
yeah, it's really cool.
Okay.
Based on yeah, based on how much the patient journals, the
Okay.
AI will the LLM will tell them, hey, these are the trends that I'm noticing
Okay.
based off of like what you've journaled and what I'm understanding about your sleep and circadian health.
Oh, so the part like that's accessible to patients, not like to break down for you, for like to help your patient
Yeah,
facing.
there's a patient facing
Okay.
AI generated insights that they get,
Okay.
and then
Okay.
on the back end, all our docs have um, AI that they can talk to. That is, it's
Okay.
basically like it's like Claude connected to the patient's
Okay.
account across all of these nights of sleep testing, CPAP data, back and forth, like text communication,
Okay.
fulfillment of orders, like basically like the whole gamut of like care coordination, operations, like sleep testing data, medical records, health exchange data. So you can kind of like talk to the patient's data, and it like helps us be more streamlined with like, hey, like what do we like what is happening? Like we get this really beautiful pre-rounding note every morning for the patients for the patients that we're going to see tonight of like, hey,
Okay.
this is what the plan was last time, and this is like what I think you should talk about to your patient today. And so it's like it's pretty cool. It's like it's evolving, but it makes it really interesting. Otherwise, it, nobody wants like a data dump. People want
Yeah, yeah,
like
yeah, yeah, yeah.
insights.
Yep.
So it's cool. It's interesting
Okay,
for
that's
sure.
very cool. So let's take a short break, and when we come back, we'll talk more about your paper examining the residual AHI on a download versus objective testing. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Have you seen Wakix pitolisant tablets clinical data? I'm Dr. Amory Morse, and I've been practicing medicine for over 10 years. I recommend exploring Wakix clinical study results to see how Wakix may help your patients. Visit wakixhcp.com to review the clinical results. That's WAKIXHCP.com.
Welcome back to Talking Sleep. We're talking with Dr. Sahil Chopra about his recent paper creating doubt over the accuracy of machine-derived residual AHI for our patients on PAP therapy. So your paper made me think a lot, right? Because what I've appreciated about this conversation is I haven't heard you just kind of focus on the AHI, right? You're talking about dipping, and you're talking about physiologic changes, and you're talking about hypoxia, and you're talking about sleep quality. And so you're taking this more holistic approach to sleep health, right? Like you're also saying sleep health, not sleep disordered breathing treatment, right? So I
Yeah.
appreciate that. And then in your paper, you also made a point about distinguishing between adherence and treatment efficacy. So talk to me about that.
Yeah, it's there's a lot to unpack there.
Yeah.
Uh,
You're welcome.
yeah, thank you. Um, you know, uh, treatment, like, compliance, I think everyone is familiar
Yeah.
with that, so we don't really have to talk about that.
Yeah. Yeah.
Um, it's like guided by insurance metrics based on a lot of old data.
Mm-hmm.
Um, but like treatment efficacy, I think is a really interesting question.
Yeah.
Like, is this treatment effective in achieving what I'm trying to achieve? And yeah, I remember like I can like hear Dr. Thomas like in the back of my head, like talking to me as a fellow, that when you prescribe someone insulin or medication for diabetes, you're not just and you give them a continuous glucose monitor. You're looking at the peaks and troughs and the valleys and troughs. You're tracking these people who have diabetes. They get an eye exam. They get a urine protein dipstick. There's so many things that go with the management of diabetes.
Yeah.
Similarly, like so many things go with the management of hypertension, and you measure blood pressure across time, and
Yeah.
and you want to measure and you want to sort of see like, hey, if I am treating hypertension, what combination of medications like really
Yeah.
improves this person's cardiovascular outcome, and I think treatment efficacy is the same for the sleep disorder. It's
Okay.
not about it's about, are we achieving restorative physiologic sleep with a solution, um, versus, are we saying, did you just take your insulin, or did you take your antihypertensive, or did
Yeah.
you take your statin? And I think like we would never I don't know. I mean, like I would never talk to a patient of just focus like that would never be the end point, right? Like, did you take your
Right.
medication?
Right.
The end point is your blood pressure controlled? Is your um like we don't do this in pulmonary clinic. Like, did
Right.
you take your albuterol?
Right.
PFTs are an outcome. 6-minute walk is an
Right.
outcome. There's all
Yeah.
these
Yeah. Yeah.
other things. Is your dyspnea score less, and all of
Yeah.
these different things. And I think treatment efficacy in sleep medicine is the same thing.
Yeah.
In sleep apnea, is this solution that I'm prescribing you helping you feel better symptomatically and sleep better objectively and physiologically?
Yeah.
And I think when we look at it that way, like so many things happen because I remember as a fellow, if someone had a PAP download AHI of less than 5,
Yeah.
and patient says, "Doc, I hate this. I don't want to use this. My wife doesn't like it," or whatever the reasons might be,
Yeah. Yeah.
and they go down the street to Dr. Khan and get a dental appliance, and you do a repeat sleep study, and the residual AHI is like 10, 11, 15, something along those lines.
Okay.
The older version of me would have said, "Hey, like the PAP was a better solution for you."
Oh, okay.
Okay.
Okay. Okay. Okay.
You know,
Okay.
like the PAP was a better solution for you because the AHI from the CPAP report was 2. Now it's
Okay.
15.
Yeah.
But like this like longitudinal testing, it puts all of the therapeutic solutions on the same playing field
Yeah.
to then see like how does dental appliance, excite, mouth taping, side sleeping, how do all of these things in combination or isolation help you improve your sleep and your breathing? And I
Yeah.
think that's where the magic of like that's the magic of like multi-night testing. It's
Yeah.
not to make a diagnosis, it's to see what combination of solutions helps you sleep and breathe better. And when we
Yeah.
talk about efficacy, part of the efficacy is I want you breathing better.
Yeah.
But dude, if you're sleeping, you know, horribly,
Right. Yeah.
like that's and you see a ton of fragmentation and autonomic arousals. Me as a sleep medicine doc, I should not be insisting to the patient that
Agreed.
that we need to try harder. Like
Yeah.
that's not the conversation. If
Yeah.
they have an low arousal endotype or a high loop gain endotype, like PAP might not be the solution. Or if it is,
Yeah.
maybe lower pressure sedative, hypnotic, something along those lines. So I
Yeah.
think it's just it unpacks so many cans of like a big can of worms
Yeah.
of the entire model of providing people sleep sleep care.
So let me ask you this then, because it just occurred to me that now you have a mechanism to have objective treatment data. So for like DOT, FAA, do they accept that? So let's say
Oh
you have somebody with a mandibular advancement device or Excite OSA or positional therapy. Will they accept this?
man, you are like really unpacking stuff, Steve. this
You're
is this is
making me think.
yeah, no, it's like you're spot on. And the way that I frame this
Yeah.
on this paperwork that I sometimes am asked to fill out
Yeah.
is I for the PAP downloads, and I don't know if I'm going to get in trouble for this, but this is like on the PAP because that's the standard of care, right? The
Right.
FAA examiner, they don't. I mean, they only know what they know,
Right.
and so if they want me to look at CPAP compliance, and I see that their residual AHI with sleep image is higher, I will go with the CPAP compliance stuff because of
That's what they're looking for.
that's
Yeah.
what they're looking for.
Yeah.
And if they're using a dental appliance or Excite or some other solution,
Yeah.
I will fill out the form in a way where I give them a 3% ASM and a 4% Medicare.
Yep.
And I'll just cop out and say, hey, clinical correlation advised, back to the
Okay.
medical examiner to let them decide. I
Okay.
That's how I've been navigating this. I don't know if there's a better
Yeah.
way to do it, but I just kind of I leave it there. But you're totally right. It's like it's an uphill battle to re-educate everyone.
Yeah.
And so I just stick to whatever whatever they are used to hearing. And then I
Yeah.
have a separate conversation with the patient as a doctor-patient through like
Yeah.
a doctor-patient relationship of, hey man, this is what, so your sleep isn't really good. Like I feel strongly that we need to do X, Y, or Z. I'll fill out this
Yeah.
form for the time being, and I just leave that with leave it within the sacred doctor-patient relationship
Yeah, because
conversation.
sometimes those like pull, right? You've got this financial sort of really strong pressure, sort of, but also the safety thing. And I think, whenever I've had conversations, even when like DOT, truck drivers, professional drivers are not happy about having to have a sleep study, but then I think when you kind of get them one-on-one, like they don't have a death wish either, right?
Yeah,
So they also recognize that, once you kind of get through the it's a racket, you're just trying to sell me a CPAP, that whole thing, to sort of say, well, I appreciate what you're saying, I get it, and I would be mad too. But full transparency, like I don't own the lab, I don't sell CPAP, I don't sell any of this stuff. Like my job is to make sure that you don't have this underlying like significant thing. And then they're kind of like, I feel like then they're like, oh, okay, yeah, I get that.
yeah, yeah,
But
and I
it's challenging.
no, totally, and I think like if so, I use the 3%
Yeah.
because I want to qualify the. I don't see the whole point is I don't look for the 3% or the 4% to make a diagnosis.
Okay.
Like the diagnosis, I think is kind of overrated. It's
Okay.
about like what are you doing to their physiology across time
Yeah.
is what the
Yeah.
patient is trying to do. And
Yeah.
so like I use this 3% rule to get them qualified for more solutions and try to
Yeah.
get the insurance to pay for it.
Yeah.
But like if someone has a 3% AHI, man, if I have a couple of drinks, my AHI goes like 8, 9. Do I have sleep apnea? I don't. I mean, some nights I do, some nights I don't.
Yeah.
Right. And
Yeah.
like I've tried using a CPAP and like my sleep is worse with a CPAP.
Yeah.
And I've tried tinkering with dental appliances and um I don't really, it doesn't feel comfortable. And
Yeah.
so like this chasing a number,
Agreed.
but I'm like a relatively high functioning individual. I exercise, run a startup, and so I think it's like it really needs to be personalized.
Agreed.
And like labeling of a diagnosis is purely for qualifying someone for a solution if I think if it's clinically indicated,
Yeah.
but it's not to like shove a solution down their throat.
Right. Because there's a huge difference between an AHI of 5 and like sleep apnea syndrome.
Oh, totally.
Right. And so then sometimes I think people like get fixated on this AHI of like 7 or 8 in somebody who's asymptomatic. And you're like, okay, well, like, why'd you have the test? Oh,
Yeah,
because
no,
whatever reason they had the test. Right. And so, yeah, I mean, so your point is well taken and sort of identifying the things that are important to the patient. Right.
yeah,
Like, my wife hates my snoring. Great. Let's see what's helpful. But if it makes your
yeah,
sleep, like if CPAP, for example, makes your sleep terrible and you're watching the clock till you hit 4 hours, like that doesn't sound like a great solution.
no,
That's not
not at all.
tenable, right? And so then we kind of change the focus from like our goal is not to get you adherent to care. Our goal is like let's treat your sleep apnea. Let's fix your sleep. And so whatever that looks like, right?
Yeah.
And so I appreciate how you approach it. I wanted to ask you this. So do you remember when they kind of changed the hypopnea scoring rule, like however many years ago, to now the 3% and or arousal versus 4%? And I think one of the criticisms was, okay, fine, they changed the rule, but the CPAP manufacturers didn't change their algorithm.
Yeah,
So, so that was one criticism of the flow AHI,
totally. No,
right?
I mean that's why it makes sense, right? That's why
Yeah.
this is prior to me being in fellowship SEMA. So, so I don't read. I've just read about it, and
in
uh,
in the historical documents from
yeah,
like the
yeah,
1900s. Yeah, okay.
yeah,
Thanks. I'm gonna go like retire to my crypt now.
Yeah.
So the other thing that really struck me is that you talked a lot about the hypoxia. And so it made me reflect
Mm,
on my own practice. So if I have somebody that has hypoxia on their diagnostic, I usually do a follow-up oximetry on whatever treatment to kind of make sure that got better. But you found a lot of residual hypoxia.
yeah. I think it was 10% of people who had an AHI flow less than 5
It was a lot.
still had a cumulative SpO2 less than 90.
Yeah.
Yeah, that's a
Well,
lot, right? That's
it's
a
a
lot of
lot. And
yeah.
it's really important in light of the sort of the link between hypoxic burden and cardiovascular stuff, right?
No.
So what's your threshold? Like, what do you do? What's the magic number for you?
If they're not at altitude,
Yeah.
um, I want it to be above 90 the entire night as best as I can.
Okay.
Um, and again, sometimes what I'll do is if I start to think, one of the things I'll do in clinic is like I'll try to figure out is this real hypoxia or not? Because sometimes these
Yeah.
oximeters, like you've
Yeah.
seen this, right? Like you put it on
Yeah.
and it's like, man, I don't know if it's really like 94%.
Right.
So I'll like even in a visit, I'll like make the patient put it on and say, I
Okay.
want you to keep this on for like a minute and then let's like check the number. So is this true hypoxia?
Yeah.
Um, if they have no reason to be hypoxic, I'll
Yeah.
give them a new sensor.
Oh, okay. Yeah, that's
Okay,
fair.
and like obviously rule out for skin tone, and luckily these sensors go on the finger, on the base
Yeah.
of the finger, not the
Tip. Yeah.
fingernail.
Yeah.
Yeah, so like nail polish is usually not an issue, and I'll send them a new sensor. And if that too is like sort of sharing like wake hypoxia, I'll send them like a different form of a sleep study, like a
You
watch
will.
pat sensor, just to
Okay.
confirm, because I don't want to go down this
Yeah.
path of doing PFTs and echo with bubble and all of this stuff.
Yeah.
Um, if they have like hypoxia during wakefulness.
Yeah.
And then, but if they do have like true hypoxia during sleep or during wakefulness, I will do the appropriate workup and
Mm-hmm.
then prescribe them O2 um,
Okay.
to get them to a better place. 1
Okay.
liter, 2 liter.
Yeah.
Sometimes you see like sleep fragmentation go down. Sometimes you see uh, less autonomic arousals. Is it because they're acclimatized more to CPAP? Is it because of the O2 itself? I think that's a separate conversation.
Okay.
But you just sort of track the physiology and see what happens. And sometimes you can just tell the patient, hey, let's take you off of oxygen tonight and let's do a week of testing without O2 and see what happens. So once you get
Okay.
them to a better
Yeah.
place. And so it's very personalized. But
Yeah.
generally speaking, the pulmonologist in me wants to keep their SpO2 greater than 90, assuming they don't have any
Yeah.
COPD or something along those lines.
Yeah. Yeah. So, so your conclusion isn't that the flow-based AHI is bad. It's just you're saying it shouldn't be the only metric, right?
Yeah, I think I'm not saying it's good. And maybe
So maybe, so maybe
yeah,
you're saying it's
I,
bad. Okay.
yeah, I don't know if it's bad. I think it's
Okay.
like something is better than nothing, right? Like at the end of the
Yeah.
day,
Fair. Yeah.
I think something is better than nothing.
Okay.
I am encouraging us being like us sleep medicine docs to
Yeah.
um, the ASM to like start thinking about how do we treat these sleep disorders as a chronic disorders with
Yeah.
some true form of tracking. I think that is like the point. That is kind of like my mission
Okay.
for the next decade is to
Okay.
get like to create adoption of longitudinal sleep tracking with medical grade diagnostics in the setting of sleep disorders.
Yeah.
And let's all as a field try to figure out how do you help someone sleep better.
Yeah. I
Because
love
I
that.
think just like fixing the AHI it's really silly as
Yeah.
like a
Well,
primary outcome.
yeah. Well, and then even fixing it according to which measure,
Yeah,
right?
exactly.
Yeah.
Yeah,
That's
100%.
fair. So, is there something else I should have asked you?
No, this is fun. This was I apologize if I rambled.
No, so no, I'm so appreciative that you're willing to join us today and kind of tell us about your work and sharing your work. I think it kind of makes us rethink about how we define what well-treated sleep apnea is. And I think you've kind of given us tools to maybe better identify the patients who have unrecognized, undertreated sleep apnea. So thank you for that.
Yeah, I think like one takeaway is
Yeah,
if you don't have the ability to do a longitudinal sleep study,
yeah,
is like if someone has a residual AHI greater than 5 on
yeah,
flow, like if
yeah,
you look at the paper, like there was this really beautiful graph that we came up with that as AHI goes up on AHI flow,
yeah,
the true burden of sleep apnea is not based on a sleep study is not linear. Meaning if AHI flow is 5, AHI CPC is 15, let's assume.
yeah,
But if AHI flow is 25, AHI CPC is not just 10 points higher.
yeah.
It's exponential.
I
So
saw that. Yeah,
if someone has an AHI flow of like say 7 to 10, that's probably close to 20. If I had to make an educated guess based off all the data that we
okay.
have.
Yeah,
So like if anyone's AHI is not less than 5, like sub 5 is
yeah,
anything above 5 is not acceptable. And
yeah,
I almost guarantee you that you will find like significant pathology. If I had to pick, if I had limited ability of doing longitudinal sleep testing, I
yeah,
would reserve it for these folks who have an AHI flow greater than 4 or 5, for sure. Like those are the people who should get it. The other
okay.
cohort who I believe should get multi-night longitudinal testing for sure is people who don't necessarily feel better.
Yeah,
Because
that's
today the standard of care is, oh, you're still sleepy, okay, like here's some modafinil and like tell me how you feel, right? Like but like when you start to do sleep testing like pre and post, like
yeah,
you'll start to wonder, man, like I just destroyed this person's sleep with a CPAP machine to fix their breathing, and
yeah,
now I'm giving them a stimulant during the day to overcome this like choppy sleep that I am
yeah,
responsible for.
yeah,
And I think when you see it, you don't
yeah,
unsee it.
yeah,
So those would be like the two people I think it's most important to track sleep longitudinally for. Or if you're starting
yeah.
like these 8109 that's about to come out. So there's all these you know um, there'll be
Yeah.
more use cases.
Well, and I think though, like it always goes back to what your patient's telling you, right? Like I think it always makes me a little bit like sad when somebody comes in and they're like, "Well, I've hated the CPAP for years, but I was just told to like suck it up because I need it." And, they've never kind of learned about non-PAP options and they've just sucked it
Hmm.
up for years and they hate it. And um I mean, it makes me sad. Like I wouldn't want to strap an air compressor to my head if I didn't have to, and if it
100%.
didn't help me, I would want someone to be like, "Oh, okay, yeah, that's not helping you. Like, let's find something
Yeah.
else." Yeah,
No, 100%. And that's why it's not like a diagnose and adios type of a problem to solve. It's like
right.
it's a chronic disease, and for chronic
Yeah,
disease management, we need to track it over time.
yeah. Awesome. Well, thanks so much for being here. I appreciate it.
Thank you. I appreciate it.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.